Yes.
Professor Hann, if I might just go back briefly to one of the issues I was asking you about before lunch, about the testing by Dr. Follett. As I understand your evidence, please correct me if I've got this wrong, you don't know now whether you asked Dr. Follett to undertake the testing or whether he did so of his own volition.
I don't remember. My memory, such as it is that I didn't ask for that to be done.
And for the reasons we've already explored, you're not able to be more precise about when that process occurred.
No, I wish I could be. My memory again is that it was at the end of 84 or early 85, but there's no way of being precise unless Professor Lowe can throw further light on it.
What would you have done with the letter from Dr. Follett, which we don't have, currently at least? Where would it have been placed?
Yes. Confidentiality was an extremely difficult issue at this time, and so it would have been in a locked filing cabinet in the secretarial admin area of the department.
And do you know...
adjacent to the laboratories in a separate building.
And do you know what happened to that letter?
I would have filed it in that way. I'm afraid not. When I left, I thought it was inappropriate to take any documentation other than very personal things away with me because they would need it in future. So I left everything behind.
Now, you referred in your statement and in your evidence earlier to the importance of social work and psychological support for the families of the boys. We know that the social worker began at the end of October 1984. What, if anything, can you recall about the availability of a psychologist or some form of counselling?
There was actually a very good professor of psychiatry, and I can't remember his name, and a psychologist. I actually contacted them very early on, and also I had known a psychologist at Stirling University called Dr. Markova, who was particularly interested in haemophilia and the way that children coped with it. I asked them if they could provide support if it was required by the staff on daycare, and I did everything I possibly could to get expert social work input, not just to this area, but also to the children with cancer and leukemia and so on, because it was a huge deficiency, in my view, in the department at that time.
So does it follow then that in terms of any kind of counselling or psychological support, it would have required a referral to an external clinician or perhaps internal to the hospital or board, but out beyond the Haemophilia Centre?
Yes, there are no. The only specific resource for the Haemophilia Centre was Dr. Pettigrew. We had, as I say, a good, but again, an under-resourced psychology department, so we could make referrals. We did make referrals from time to time, especially in the other areas, and they were available. But it was really, the problem in that respect is that what you need is ongoing support. And psychologists, especially if they're very under-resourced in dealing with child protection issues, eating disorders, so on and so forth, and the death and bereavement counselling of many of my patients, they just don't have the ability to follow things up. So they basically give diagnostic help. If you think a child is becoming depressed, or if you think a parent needs help, they will give in that era would give diagnostic support, and they always were available to speak with Anna, Sister Murphy, and later on the social worker if a child needed specific counselling.
Could we look, Seamus, please, at MACK 301021. This is a letter from you to Dr. Forbes in October of '85, headed Haemophilia Counselling / AIDS and HTLV3. And it refers to you having applied to the Haemophilia Society for a grant to pay for a clinical associate. The project was to investigate an interventionist approach to the long-term psychosocial problems of families with haemophilia, including AIDS and HTLV3 antibody positivity. The Society turned down this application, the reason being it was not relevant to their first priority, i.e. AIDS and HTLV3 positivity. Thus, once again, I'm in the position whereby I will be financing a post directly concerned with haemophilia management from leukemia research funds. This post will be taken up very shortly and will, of course, involve intensive family work. What was the issue here? Can you recall?
Can you give me the date again at the top?
It's the 16th of October, 1985, I think. Shemit, could you just...
Yes, it is.
That's fine. I don't have a great deal of recall of this, to be honest with you. I had been trying throughout this period. Professor Stone, I think, was the professor of psychiatry. Not exactly sure. I think he was. And I had spoken to him numerous times about the problem, not just in haemophilia, but in the children and families with leukemia and solid tumours who needed much more psychosocial support than they were receiving at the time. Basically, by this stage, it was obvious to me, having spoken to the families in the clinic and with Dr. Pettigrew reporting back to me, that there was a need for more, as I've just described previously, more long-term involvement with the families from the psychological, social work, family therapy point of view. And although Anna was extremely good, and so was Sister Murphy in their own way, in providing the clinical support and social support, etc., I believed we needed, and I think Dr. Markova and Sterling had advised me too, having met a number of these families and looked at various problems, that we needed long-term interventionist psychological, or at least diagnostic psychological treatment with follow-up, and not just a usually one-off approach which had been available previously.
Were you able to obtain that long-term input at any point before you left to go to Great Ormond Street?
I'm really sorry, I honestly can't remember. I hope so. It sounds from what I'm saying that I was intending to use private charitable funds, etc., for a purpose that it was never really intended, which unfortunately I had to do from time to time because of necessity. So I expect that I had done that. I think Dr. Pettigrew would have known better than me, but there was certainly more psychological input from 1985 onwards.
You said in your evidence to the Penrose inquiry, we fought constant battles on behalf of our patients to prevent them being treated like lepers. Could you expand upon that, please?
Yes, there were a lot of good people, and unfortunately a number of bad things that happened, some of which I've given evidence about before, but they may seem trivial, but they're incredibly important to the families. And I could list them forever, but basically the sort of important ones were the extreme difficulty in travel. They couldn't get travel insurance. When they grew up, of course, they couldn't get mortgages. And there was a lot of effort. Actually, the Haemophilia Society, I think, in particular, and I helped them, were able to get insurances eventually. That's just one example. They couldn't get through customs because they had needles, etc., and were identified that way. Within the society in general, there were major problems in some schools, and other schools were amazing. They were ostracized in schools. Some children had to be taken out of school or changed school. It was extremely difficult. Anna and Sister Murphy, I know, attended schools to try to deal with problems, but always dealt with them in the context of haemophilia in general. there was a huge amount of adverse publicity, and the publicity was often very unhelpful. And one thing that governments seem to have got a little bit better is not putting out adverts that just frighten people rigid. Even my own children came to me one day and said they didn't want to die of ignorance, which was the main advert at the time. Within the hospital itself, there were a couple of areas that were a problem. Basically, portering staff. I ended up one Easter pushing children into radiology myself because nobody would take them. There was a hospital policy promoted, which I can't remember if it ever happened, where any child with haemophilia, no matter what was wrong with them, had to be reverse barrier nursed, which meant they got their food on paper trays. And I even heard one person having it shoved under a door. But I have to say that the sister on our ward was very good in that respect and put down any stigmatization. One of the very good things was our dental department. They were marvelous, actually. I had a terrible run-in with a Deputy Chief Medical Officer who is a public health doctor who wanted the list of our patients so that he could disseminate that to all dental surgeries so that they didn't get infected by our patients. I mean, to say that they were pariahs to him was an understatement. I was summoned to the Home and Health Department that was a public health doctor. I was summoned to the Home and Health Department for an interview with the Deputy Chief Medical Officer who said that he might have to put a black mark on my copybook, and I said he was very well, he can do what he liked as far as I was concerned. And it wasn't, unfortunately, in the era of freedom of information, or I might have done something about it. So, there were a lot of difficulties. We had to be very careful about stigmatization. Within the laboratory was probably the most difficult clinical problem. Initially, as with, I'm afraid to say, the COVID-19 outbreak, there was great overreaction. I constantly reminded them that universal precautions in the laboratory, at home, all the rest of it, was what came out, the good that came out of the hepatitis B tragedies. Sticking stickers all over samples does nothing. It does not identify who is at risk, and it was a complete waste of time with COVID-19, for instance, because as you know, asymptomatic transmission occurs. So yes, I'm sorry, another long-winded answer. There were a lot of challenges for these families. They suffered a great deal. They were stigmatized. They were made into pariahs. There were good responses, and then eventually everybody came to their senses, but it took quite a while.
Did you have any involvement with the transfer of patients to the infectious diseases unit at Ruckhill for treatment once any of the boys had become particularly unwell as a result of AIDS?
No. In fact, I don't think, I certainly don't remember any child becoming or develop an AIDS-related syndrome. As I've explained, I was expert in the area of infection in the immunocompromised. I have managed a lot of children with pneumocystis jirovecii, and I knew a lot about prophylaxis with regard to preventing such infections. If we had got to the stage where there was an AIDS-related illness, then I would have had to refer the patients there because there was really no local expertise. Thankfully, at Great Ormond Street, the setup within infectious diseases and virology and microbiology was really excellent.
Prior to your departure for Great Ormond Street, had there been any advanced planning for the eventuality that one or more of the boys might require admission to Ruckhill?
No advanced planning for that, because at that stage, I think by that stage, I can't remember exactly when, we'd realised that Kaposi sarcoma and things like lichen planus and all the rest of it, wasting syndromes, were not occurring in our patients and were less common anyway, as far as I knew, than in the other populations that have been described to that point. So basically, the planning consisted around advice about universal precautions. Yet again, the advice with regard to the identification of pneumocystis, which would involve persistent cough, etc. Discussions with experts in London usually of when to start prophylaxis with cotrimoxazole, which have been shown to be very effective in leukemia patients. We had a lot of leukemia patients on that prophylaxis. I can't remember whether or not we started those patients on it. It would have depended to an extent on their CD4 counts, which were done for us at the Royal Infirmary, I believe.
In the period 1983 to 1987, was there any input from or advice sought from hepatology experts in relation to your patients?
I knew the hepatologist at Great Ormond Street very well, Dr. Peter Clayton, and I knew the infectious disease doctors there very well indeed. And some of them were my colleagues for years previously, and I had many discussions with them about whether there was anything else we should be doing, or whether there were any tests we should be doing. They asked me about doing liver biopsies, and I remember a number of conversations over whether it was worth thinking about doing any more enhanced scanning rather than liver biopsies, but at that stage there was no real evidence. I don't know what happened subsequently. There was no real evidence that helped much. Basically, the advice was keep doing the liver function tests, seeing if they developed any other symptoms of hepatology.
What about at York Hill, though? Was there any ability to access hepatology?
That was at York Hill.
Oh, that was while you were at York Hill.
When I went to Great Ormond Street, there was the hepatology is very centralised in the UK, and it's the one area where there is no major department at Great Ormond Street, but there is a hepatologist within the gastro department now, so who I happen to know very well. So within York Hill, we would have had to contact hepatologists in other hospitals, and I would have taken advice from Gordon Lowe as to who to contact, and he would have been able to give me a lot of evidence in that respect.
In relation to the period after the introduction of the SNBTS heat-treated product in December 1984, for I think about 2.5 years until April of 1987, the heat-treated concentrate you would have been using for the care of patients with haemophilia A would have been NY, I understand.
I'm sorry, I can't remember that.
In any event,
it was heat-treated 68, was it 68 for 24 hours? Or, that's all I can remember.
Whatever the precise name of the product, is this correct? It was believed, and we've seen your exchange with Dr. Cash, believed to be sufficient in relation to the eradication of HTLV3, but it was understood that it did not have the same effect in relation to non-A, non-B hepatitis. Was that your understanding?
It didn't have the same level of activity. I'm sorry, I can't remember whether that heat treatment had any effect at all on hepatitis C. We did know that it wasn't effective enough because there were, I believe, subsequent, I don't know in my children's population, but in other populations there had been seroconversions to hepatitis C at about that era.
Did you introduce any particular system or take any particular precautions during that period to ensure that previously untreated or minimally treated patients would not receive that concentrate and thus be exposed to non-A, non-B hepatitis unless absolutely necessary?
We continued with the previous policy, as far as I remember, which was to use cryoprecipitate in new patients. As I've said, in that era, it was a relatively small department with relatively few new PUPs, if you like. There's no question in the mild or moderates. There are very rare moderates who do bleed a lot more. But in this, as far as severes go, it would be very few new patients, and they were very young. And I think Dr. Pettigrew may have told you that in any case, they were usually treated with cryoprecipitate initially, because chemotherapy in very young children
I think we lost you there for a moment, Professor. The picture is occasionally breaking up. Would you be able to repeat that last answer you gave? You said home therapy in very young children.
Oh, sorry. In very young children, we, in any case, cryoprecipitate was usually the standard of care in that era, unless there was a severe episode like a bad, nasty head injury or whatever. But as you probably know, in the first couple of years of life, such episodes are uncommon anyway. Many of them don't even present for the first year or so of life. But if it was required to maintain definite hemostasis and for that to be continued over a period of time, then cryoprecipitate would not have been a good solution for several reasons, not least because even during this period, we were still having some difficulties in getting factor assays done in the laboratory because of fears over cross infection.
Can you recall what efforts were made to address the possibility of infection with HIV for haemophilia B patients during the period up until, I think, October 1985, when a heat-treated factor IX product became available from SNBTS?
Gosh, it's stretching my memory. We had very few patients by chance with Christmas disease, haemophilia B. I honestly can't remember it, maybe one or two. And in those patients, the only alternative is fresh frozen plasma, which is even more difficult than using cryoprecipitate because the amount of factor IX that you get in that is minuscule compared to the concentrate. So if basically, again, the idea, and it also doesn't respond to either cryo or DDAVP or whatever. So basically, if there had been, and I don't remember any episodes to be honest, where it also tends to be, there is a tendency for it to be a milder clinical manifestation as well. Not always, but it quite often is. My memory, such as it is that we rarely needed to treat patients with Christmas disease, and that when we did, we would have tried to avoid the use of concentrate during this period of time where possible, and even considered the use of fresh frozen plasma, although it was a very poor treatment.
I want to move next to some questions about Great Ormond Street. When you arrived, the concentrates that would have been available would have been, I think, entirely heat treated. What was your understanding, or what did you learn about what the approach to treatment had been in the first half of the 1980s at Great Ormond Street?
Well, I was there, yes, during that time. Basically, when I was a lecturer, I was there. You have the dates, and I've forgotten them again. It was prior to 1979, so it was about 1977. The patients that I saw were almost all on concentrate, and a very high proportion of that was commercial. I think a lot of it was armor. That's just a memory, but certainly there were no patients that I met during that period of time who were on home therapy with cryoprecipitate. Again, there was no written protocol at that time when I was a lecturer. Sorry, are you talking about 1988 now?
I am, but I was asking what you knew of what happened before,
Right.
and by all means fill in that gaps by reference to your own direct
Yes,
knowledge from working there too.
I was there for 2 years, so I can remember a fair bit of it. The cryoprecipitate, there was no written protocol. There was an understanding that patients with mild haemophilia and von Willebrand's disease would be treated with cryoprecipitate. There was a very small amount of use of DDABP. We used quite a lot of antifibrinolytic agents, tranexamic acid, EACA, etc. For patients with Christmas disease, they were treated, as far as I remember, exclusively with fresh frozen plasma. And the patients with severe haemophilia were, by that stage, the vast majority of them, even though they'd only been there for about a year or so, were transitioning to home therapy. And eventually the idea, as in Glasgow, was that they would transition to adult care once they were self-treating and established in secondary school at about the age of 12 or 13.
And when you returned to Great Ormond Street as a consultant, following your 4 or so years at York Hill, what, if anything, did you understand or learn to be the position about the circumstances in which Great Ormond Street patients had been infected?
It had been managed by Professor Hardesty and one of the lecturers, Dr. Bull mainly, in collaboration with the infectious disease department and one of the lecturers there who was given that as a specific role. There were quite a large cohort of patients, I don't know the number, I'm afraid, who were infected with HIV, a few of whom had developed problems, one of whom I remember had developed autoimmune thrombocytopenia with a low platelet count. But there weren't a great number of patients, very few in fact, who were developing overt signs of an AIDS-related type syndrome. Where that happened, the studies had already been undertaken and were in progress with AZT, which was led by the infectious disease department and the professor of immunology, Professor Levinsky.
And as and when patients of Great Ormond Street did develop AIDS and opportunistic infections, how was their care and treatment managed? Were there joint clinics, or was it a question of referral to the infectious diseases unit?
I didn't really run joint clinics because, yet again, I was pretty much on my own. What we did was they would be seen in an infectious disease clinic, and then I would see them in a clinic, either the haemophilia clinic or in the haemophilia centre, which was very limited initially, but at least it existed slightly. The management of these patients was essentially by the infectious disease and immunology team with the hepatology input, but also we relied a very great deal on two clinical nurse specialists with counselling, with specific children's counselling training in haemophilia and infectious diseases, and the infectious disease lecturer, who all of whom, if you like, coordinated as a team. They also had a lot of input from psychology and social work. It was a very well-resourced area.
When the test for hepatitis C became available, what can you recall about the process for testing patients for hepatitis C at Great Ormond Street, the bleeding disorder patients?
Thankfully, it was a great deal better. pre-test counselling was intensive and expert. From the, I think there was eventually even a hepatitis C clinical nurse specialist, but initially it may well have been from, yes, in fact there was, from the infectious disease team and to a certain extent ourselves, because this was across the board. There were, being a tertiary quaternary referral hospital, there were a lot of patients who'd received a lot of blood products for cardiac disease, for immunodeficiencies, for all sorts of other things that were not related to haemophilia. And of course, all the leukemia patients were at very significant risk. So it was a very big undertaking. It again required retesting and gold standard, as it was called, testing. But it was, by this stage, I suppose we'd learned our lesson, and pre-test counselling and post-test counselling and ongoing support was provided to every patient who was about to be tested, whether or not they turned out to be positive.
And what, if any, role did you have in the treatment of patients with bleeding disorders who'd been infected with hepatitis C, as and when treatments became available in the 90s, interferon and ribavirin and so on?
As far as I remember, as I've said, I think there was only one patient between 88 and 2006 who required interferon therapy. It was extremely poorly tolerated, but it was not. I always believed that specialization and expertise was important, and I certainly didn't dabble in infectious disease management or HIV management or hepatitis C management, other than looking after their haemophilia and ensuring that the coordination between the multidisciplinary approach worked, which was also particularly the role of the nurses involved who worked together.
And at what age typically did the bleeding disorder patients at the Great Ormond Street cease to be the responsibility of Great Ormond Street and be referred to an adult service?
It depended on what was wrong with them. If they were not infected, they were usually transferred. And again, adolescent management in the UK has never been brilliant. It's a great deal better now. We've worked very hard, and we then my successor, Dr. Liesner, my colleague and successor, managed to set up a transitional care consultant between ourselves and the Royal Free, and some of the patients south of the river went to St Thomas's. So the answer to your question is that we would expect them to be on self-therapy and established in the secondary school. That establishment was managed from as an outreach from the department. Now, if they were infected with hepatitis C or HIV or both and had no problems whatsoever and were not requiring any treatment, and I don't know if there were any of those, they would also transfer to those centres with the transitional care put in place. Those patients who sadly were running into major problems actually stayed between ourselves and UCL, where there was a lot of us had joint contracts with UCL. The infectious disease people did, the immunologists, some of them did, and they managed the patient between ourselves and UCL. We weren't allowed to admit patients over the age of 15 to Great Ormond Street except in exceptional circumstances. So it was essential that there was some sort of joint management between those two centres, because they had a great deal, that's where Dr. Tedder worked, and there was a great deal of expertise there in HIV and hepatitis C, and they basically managed the patients. And I say it would have been foolish for me to interfere with that, but we made sure that their haemophilia was also managed and they weren't stigmatised in any way.
Professor Hann, I've got some more general questions for you now, not specific to York Hill or Great Ormond Street, but to be answered as you're best able to. Did you consider that the management of children with bleeding disorders gave rise to different ethical considerations than the treatment of adults? And if so, in what respects?
Yes, absolutely. I suppose I would say that, wouldn't I? I'm a paediatrician. Children are not small adults. They have different disorders, diseases. They have different responses to things. They have much different educational needs. They have different psychological needs. They need expertise. This was a question that arose, and I won't ramble on, but this is a question that arose repeatedly within this particular area, which was almost unique in medicine in that many children were looked after within adult centres and with adult physicians looking after them, maybe having some advice from paediatrics. In Glasgow, that was not the case, and latterly, although only quite a lot latterly, it was the case in London that a lot of children were looked after in major adult centres by adult treating physicians. It would virtually be a story of my life, if you like, if I were to say what's different about paediatrics. Does it matter that you're pediatrically trained? Yes, it does. Does it matter that you're in a centre that has multiple paediatric subspecialists? I believe so, which is one of the reasons why I moved. Does it matter that you have input from people who are trained in both counselling and communication and all the rest? And that's not just psychologists, the nurses in particular, and the social workers with family therapy counselling training are a vital element of it too. So yeah, they also obviously do have some different diseases. They have different ways that they present. I mean, children with pneumocystis do present somewhat differently. For instance, I had a lot of experience of that. So I do think that children should be managed within centres where there is a lot of hands-on paediatric experience, not just the great almighty doctor, but the whole team. And the what we used to call the seamless roving raid on the street. In other words, everything around it that's required for dealing with children with long-term disease. And that finally, by the way, doesn't mean that we had to do everything. We have, for instance, a hub and spoke approach towards leukemia treatment, etc. And we empower centres like Watford or Welwyn or the Whittington or whatever to co-manage those patients with us. That's more difficult to arrange with haemophilia because it's far less common. It's less common and much more chronic. But anyway, sorry, that's a long answer.
Are there, in your view, any different ethical considerations that might arise as between the position of children and adults when it comes to treatment that might be regarded as experimental or particularly high risk?
Yes, there are, and I've already explained to you that the involvement of people like play therapists and all the rest of it, explaining. It's a question of explanation, appropriate explanation, and explanation that doesn't just frighten but informs appropriately and honestly and transparently. The ethical considerations are I've read the ethical report, which is very good. The problem with ethics when you're on the ground is it's often very difficult to decide what is ethical and what is not. The legal aspect of it really isn't the major issue, although it was clarified with Gillick principles and so on. I was very unhappy prior to that children were assumed not to be able to give consent to anything. There are episodes, and I give you the example of, I know it's not the same, but children with bone tumours, for instance, where amputation is an issue and the child may be 10 or 11 or whatever it may be. These are difficult and may refuse therapy Now, do you override that, or do you regard them as competent, or what do you do? We set up a forum. We had obviously an ethics, not department, but we had a paediatrician who trained with Serene Kennedy, who you may know, and who gave us advice. And we also had an ethical forum, for instance, for children who had multiple congenital abnormalities. And of course, that's been in the press in the near past in Great Illustrate itself. These are very, very difficult issues sometimes, where parents expect treatment that doctors believe to be futile, where children refuse treatment and the parents want it, where, all of these things come up and are not theories. They are actual practical problems. I was very lucky at Great Illustrate. We had usually very good advice, and we're surrounded by people who had the best needs of the children in view.
In your witness statement, you made an observation that blood transfusion centres in England seem to function like individual fiefdoms. What was the basis for that view, and are you able to elaborate upon what you meant?
Yes, there's no doubt that that's how it worked, in my view anyway, when I was training, and that would be in the mid-1970s. It was set up, like a lot of things in the NHS, piecemeal post-war, based on people who've been in the army and places that have been set up to provide blood and such like. Not necessarily in the right place and not necessarily with all the best people involved, not necessarily, or all the appropriate expertise. I don't know when this changed in the UK. It certainly had changed by the time I got back to Great Ormond Street. NHSBT is a world-class institution with fantastic scientific backup, which we rely on a great deal in Ireland, by the way, even after Brexit. They work as a whole team across the country now. For instance, they have centralised things like frozen storage of rare blood groups in Liverpool. And they have groups of scientists and technicians and laboratory scientists who advise them on things like blood product irradiation, and particularly the foremost fear still, transfusion-transmitted infections, which is a day-to-day issue still within blood transfusion. So in those days, it was down to the local director. It was run by a doctor who was sort of all-seeing and all-pervasive, and who made the decisions and who seemed to run the budget and everything else. So it was pretty much a fiefdom. There were major problems in the late 1970s because of activity, and which came to be carried out in the courts subsequently. And I think that was one of the drivers to put it right.
You identified also in your witness statement your concern that the training of all clinical staff with regard to blood and blood products and transfusion-transmitted infection is still not satisfactory. And you say for some reason this area is still not taken seriously enough, and mistakes such as wrong and inappropriate transfusions continue. Again, could you elaborate upon that, please?
Yeah. It's obviously improved, and we're, within transfusion, doing everything we possibly can to ensure that, for instance, within Ireland, we now insist that all trainee staff, when they come in, have carried out the e-learning facility and been accredited on it before they come. We still have to put a great deal of effort in via our one of the great things that came out of this tragedy is that haemovigilance and governance of blood products improved out of all proportion with the appointment in every hospital of haemovigilance staff who report directly to the Hospital Transfusion Committee and the executive team. So it's unfortunately the case that within medical education in the UK, I can tell you, whatever those educators say, when they come to the hospitals, their attention to detail and their knowledge is often initially not sufficient. And I'm not talking about haematologists here because that's rammed into them. But in general, there are still some doctors out there who regard a bag of blood as something that sticks your hemoglobin at 1 gram or so if you're an adult, and that's about it, despite the fact that we've spent forever producing leaflets for patients and getting consent organised, etc., for every transfusion.
In your evidence to the Penrose inquiry, you described this. There was inappropriate use of blood products on a regular basis, particularly by surgeons, who often attributed near magical properties to products such as fresh frozen plasma and cryoprecipitate and whole blood. Were you talking about a particular time period then, or is that something that you've been aware of throughout your career?
There is still, it's improved a great deal. There was a lot of belief. It was a bit like phlogiston, or anyway, it was a pseudoscience type belief in things like whole blood. It gave you everything you needed, bar the kitchen sink. And it stopped you bleeding. It plugged up holes. It stopped surgical bleeding. It might even have treated infection or whatever. As I say, the education in those days was wholly inadequate. It has improved a lot, but there is still inappropriate use from time to time, which is monitored through the blood transfusion service attending hospital transfusion committees, through IRs, as they're called, incident reports, which every hospital in Ireland anyway has to produce. And we look at things like, why are people still using cryoprecipitate when it is no longer the safest drug for surgical bleeding following cardiac surgery, for instance? Why are they still doing it when the evidence that exists? And unfortunately, one thing I'll finally say is that I grew up throughout the 1970s and onwards with the management of children with leukemia. It's been a great success story, and it's based on proper data, proper clinical trials, proper outcome, proper governance and overseeing of those results. Blood transfusion did not work like that, has not worked like that. And the number of clinical trials, randomized trials that's carried out in this area is still far too small. This has been recognized by the Cochrane reviews, etc. I've recently looked at two things like screening for CMV negativity in blood products. Since the 1960s and 70s, there have been 10 trials only. Irradiation of blood products for patients who are having bone marrow transplant, 0 trials. It's still a bit of a Cinderella area of medicine.
You've referred in the course of your evidence today on a couple of occasions to the issue of self-sufficiency and wondered whether we would go back to it. And this is my invitation to you, Professor Hann, to go back to the issue. You deal with it in your statement and talk about the fight for self-sufficiency. What would you wish to say on that issue?
Yeah, I won't keep you too long on that because it may well be irrelevant. Self-sufficiency means that you can treat every patient optimally. That would mean being able to treat everybody with prophylaxis, which is a huge extra drain on resources. And also, as big a problem, being able to treat the inhibitor patients with massive doses of factor VIII. There was no way that the UK was in a position, or appeared to be unable to be in a position, to get to that level. I can't remember the doses that you would require for prophylaxis per year, but it's greatly increased for for treating inhibitors, it's absolutely massive, and it's a massive cost as well, of the order of something like $500,000 for a year's treatment. So you could say, well, neither of these things were established. Well, in actual fact, the evidence from the 1970s in Sweden were fairly compelling, and we were able to confirm, or Dr. Liesner was able to confirm that, even in patients who had very bad target joints. The evidence with regard to inhibitors came from Germany, which has always done much better than us in this area, where they were treating, I think they were called Bonn protocols and so on. They were treating patients with very high dose, so-called immunotolerizing treatments, well before we were able to fund that or get enough treatment in the UK. Things have changed radically, but actually being at a full level of self-sufficiency, we were a very long way off that. Scotland was much closer and probably could have taken on prophylaxis for the majority of children eventually, but obviously the finding and verification of recombinant products solved the problem, if you could afford it.
You also refer in your statement to two concerns. One, the lack of a national expert advisory body or group of some kind during the 70s or 80s. And secondly, the lack of national guidance.
Yeah.
Again, can I invite you to elaborate upon how, in practical terms, that could have assisted?
I'm very grateful to you for asking me that genuinely, because it was, you know, if nothing else, good should come out of a tragedy like this. And I've already mentioned some of the good things: the governance of blood products, the traceability, which is a legal requirement in Ireland now. But there are some things that have not happened. I was going to say this in my in a concluding statement, but if you've a few minutes, I'd like to address it now, because I think it's I think it's fundamentally important, actually. This was an era where we were I believe, coming out of a very patronizing era in medicine. There were still some doctors around who believed that they were some sort of god or whatever, but not within my haemophilia community. What we needed was not a bunch of doctors meeting together with a bit of advice from somebody who has some interest in some area related to what we were dealing with. What we needed, and this was not solved with hepatitis C entirely, and it certainly was not even answered when we came to prion disease, and I've said that in my statement. What we needed was, and I'm afraid to say, it has to be either governmental, or at least it has to be in a position to give you something in authority which you know you can follow with knowing that it is correct and it is coming from the right sources, etc. Basically, I would describe the situation that we were in was in some sort of maelstrom, in a whirlwind of different advice based on very little in science coming at you from all different corners, and consensus very difficult to achieve in certain areas, including non-A, non-B hepatitis. It was very difficult, but it would have been a great deal better if there had been central guidance, if we had had some sort of SAGE committee or whatever at that time. I'm sure that's much better now. I sincerely hope it is. But it's taken this pandemic for this to improve. And I'd just like to say two other things, really, because I think it really is of fundamental importance, and I will be quiet after that. One of the major problems we had at that time was with public health input. Some people will hate me saying this, but the fact is that it was either not much help or it was actually unhelpful. What we needed from public health was experts who had real experience of dealing with public health issues, and not just preventative health ideas, which obviously is a very important part of public health, but actually real training and real experience of dealing with epidemics, pandemics, endemics, whatever you like to call them, real experience. My experience subsequently is that this has improved, but it's still not adequate. And you only have to look at Ireland, where I work now. Public health doctors are not even recognised as consultants and are not paid as such. It's a disgrace. It's being put forward and brought forward so many times. If you ignore history, you are undoubtedly doomed to repeat it. And I think that training in those areas still has to be addressed. It has to be addressed with proper hands-on training. And there are people, Dr. Navarro, various others, who are very experienced. One of the leaders in the WHO is Dr. Ryan, an Irish man. So the expertise does exist, but it does not exist across the board and to a level which would have helped us at the time or subsequently. The other thing that I really wanted to say was that to come out of this and to believe that people are going to start taking viral infections and transmitted infections seriously immediately or very soon has been a very, very disappointing process. Most virologists now accept that we are going to invariably suffer such plagues and we need to be better prepared. This is an existential threat to humanity, possibly even as serious as that of climate change. We've already in the blood transfusion services had to deal in the Americas with Zika virus, causing major neonatal problems, with West Nile virus, for which we have to test in Ireland at the moment, and many other problems such as, for instance, hepatitis E, which is very common in Ireland and the UK at the moment and is associated with a degree of uncertainty. But worse than that, there are other viruses coming through which get very little publicity. For instance, Nipah virus has already killed at least 300 people in Malaysia. It comes from bats through pigs. I don't think anybody else ever again is going to really look at porcine products for human use. Hendra virus has killed a number of people in Australia and comes from fruit bats, which really takes me on to the final point that I wanted to say as a conclusion, which is that, this is an area that should be foremost in research funding, in government priorities, and in all aspects of medical training. Also, that research needs to be between the veterinary and the medical fraternities. There's very little, there is some, but there's very little collaboration at this moment in time. That must be improved. Experts in zoonoses need to be part of the advice that you get during these epidemics, along with behavioral scientists, psychologists, and all the other things that we didn't have at the time. We still haven't learned all of that. And until we do, we are going to have further problems which are going to be a major threat. And just one final thing, if people don't think research is impossible, just think for a moment about how is it that bats are the carriers and live with these viruses within them and have methods of control of these viruses within them. That should be a very, very important research protocol within any country at this moment in time. So I'm sorry, I just wanted to take the opportunity to say that this was a terrible tragedy. Nothing worse in my experience of over a third of a century of treating children. But we had hoped that good would come out of it. A lot of good did come out, but there are still major things that we have not learned that I hope that this inquiry will bring to the forefront. Thank you very much for allowing me to say that.
Professor Hann, so I've got some specific questions that have been suggested to me by recognised legal representatives of core participants, but we need obviously to give the opportunity to them to suggest any further questions. I don't anticipate there'll be a huge number more, but bearing in mind the need to give that opportunity and the fact that the picture is breaking up somewhat from time to time, I wonder whether we could take the break now, and then when we come back, I can finish the questioning of Professor Hann by reference to the further suggestions I might receive from call participants.
Yes, indeed. 3:30. Take a break till 3:30, Professor.
Thank you.